Hello, I'm Dr. Bindu Bahuleyan, one of the plastic surgeons at NYC Health Hospitals at Kings County. I'm very excited to share with you that we have started our body contouring procedures at this hospital. I'm very lucky to have the opportunity to present an overview of this. Body contouring. The following slides, we're going to go through introduction, history, physical examination, timing of the surgery, pre-operative evaluation, overview of the procedures for each region, post-operative care, complications. Due to time limitations, I will not be going through the technical aspects of each procedure. Body contouring. It surgically addresses the excess skin from various parts of the body secondary to weight loss. At KCH, we are going to focus on those who had bariatric surgery. Our aim is to improve any functional impairments from the skin excess. Also addresses the aesthetic and psychological components of the impairment. Post-bariatric patients have history of significant comorbidities and body contour deformities. Post-bariatric body contouring procedures are more challenging compared to their counterparts. So, we notice that body contouring procedures are increasing nationwide. Why is it so? Because there is an increase in obesity in our population. There's also a better awareness of benefits of weight loss in the public and the success of weight loss surgery. So, our main goal of the surgery is to provide a safe, effective, and a reliable technique. It's very crucial we have a clear understanding of the patient's expectations. Extent of the scar needs to be discussed with the patients, and they have to be comfortable with that. These patients also have very significant comorbidities. They could be any one of the following or a combination of them, which include hypertension, diabetes, coronary artery disease, lipid abnormalities, obstructive sleep apnea, asthma, peripheral vascular disease, depression, osteoarthritis, to name a few. Many of them would have resolved some of these comorbidities, or some may still continue to have them. In the history, it is important to assess and ask for discomfort, difficulty in ambulation, intertrigo secondary to excess skin. It's important that we take a very detailed weight history. What is the patient's current weight, maximum weight? What was the minimum weight? And calculate the body mass index and evaluate current BMI, maximum BMI, minimum BMI, period of weight stabilization. Important to ask for history of pregnancy and any previous surgeries. Important to include psychological symptoms, and please be sensitive in this approach. We need to also ask if they are taking any supplemental medications for weight loss, because these need to be stopped prior to the surgery. Very crucial to assess their nutritional status and to see if they're taking any supplements for that. And also to see if they are being seen by their bariatric surgery team. Also, ascertain if the patient has reached their ideal body weight. Why is that so? If so, the recurrence of soft tissue laxity is less and nutritional metabolic status is optimum. It's important to document the ideal body weight. Inquire the history about smoking, DVT, hereditary coagulopathies, any other comorbidities that we haven't spoken so far of. And last but not least, it's important to ask about their family support for post-op recovery, because it's very crucial for them to recover. Contraindications for surgery are any severe medical disease which will not allow them to have a general anesthesia. Relative contraindications are smoking, for which they at least need to stop it 1 month prior to the surgery. They ideally need to be a BMI of less than 30, but a BMI of 35 we can ask and explore on an individual basis. Very rarely we would do them about that. And that would be in conditions where they have large pannus and they're wheelchair bound, and this surgery will help them ambulate. Also, check for coagulopathies. They need to be corrected prior to surgery. Any disorders that would impair wound healing should be also considered as a relative contraindication. Our physical exam would be considered the most important thing, and it should be done as a thorough full examination, just like any patient that you would do, with special importance to the areas of the weight loss that they have attained. Look for the skin and subcutaneous tissue excess. Assess the quality of the skin, the striae, intertriginous dermatitis. Look for lymphedema, any stigmata of lymphedema. When it's abdomen, look for abdominal scars, hernia, laxity of fascia. Obtain standardized photographs. Why do we talk about skin excess? Because it can cause infections. There can be infections under the pannus. There can be rashes under there. The patients will complain about difficulty in maintaining hygiene. They have constant discomfort. They have difficulty in exercising or ambulation, impaired sexual activity, and low self-esteem. Timing of the surgery. This is very critical. We need to ensure that they have achieved their ideal body weight, which is approximately about 12 to 18 months after the bariatric surgery. And also after that, they need to have 3 to 6 months of weight stabilization. We are looking for an ideal BMI less than 30. Why is timing so essential? Because that is the time period it takes them for their metabolic and nutritional deficiencies to be optimized. And also a stable weight can be attained, which is very crucial for wound healing. If we don't do that, then we are looking for complications that are a little higher. Pre-op visit is important because we need to review the procedure in detail with the patient, perhaps with some illustrations, go through the complications, review the photographs of the patient with them, highlight any existing asymmetries in some cases, and point out to them that it cannot be corrected completely. You need to go through with the patient about the restrictions post-op that they have to maintain, and about their recovery guidelines, about drain maintenance, about compression garment use. Review with them the post-op medications, what they can take and what they cannot. Stress the importance of early ambulation. And again, there's a second opportunity to assess their support system. Pre-op evaluation, again, we need to record the highest, lowest, and current BMI. Optimize comorbidities like hypertension, diabetes, cardiac problem, thrombogenic propensity. Appropriately counsel medicine, cardiology, psychiatry, bariatric surgery, nutrition services. Ensure to address any underlying psychological issue, correct any underlying nutritional deficiency. This is not your regular pre-op workup with CBC and CMP. We need to obtain vitamin levels, calcium, ferritin, etc. Ensure patient has support to go through the surgery and recovery time. At this time, we could also discuss about staging of the procedures. Patients sometimes tell them that they want one procedure at a time, and you have to listen to them, and the choice is made based on patients' priorities. This is, again, one more chance to establish realistic expectations with the patient. Staging versus non-staging needs to be discussed with the patients. Advantages of staging, that would be combined procedure, less anesthesia, as opposed to non-staging where they need to have a couple of procedures. These are advantages and disadvantages that need to be discussed with patients and have to be done on an individual basis. If it is going to be staged, we have to make sure they have at least 3 to 6 months between each procedure so that they can recover from that. There are certain steps that we need to pay attention during the pre-op and intra-op period. Communication with the anesthesia team is very important. Discuss with them about the patient position along with the nursing staff. Discuss with the requirement of padding at pressure points. It's important to prevent hypothermia, so warm blankets, warm fluids need to be used. Pre-op antibiotics need to be given, along with redosing when required. Deep DVT prophylaxis, mechanical and chemical, which is latter based on the Caprini score. Ensure patient has adequate fluid replacement, watch out for the urine output, and obtain a strict glycemic control in diabetic patients. Now let's focus on each region very briefly. Excess trunk and abdominal tissue. The aim is to remove the redundant tissue, flatten the contour, tighten the fascia, address any monstosis, and repair if any hernia. The presence of hernia should be established prior to the surgery, because in that case we can involve the general surgeon appropriately. From our perspective, we should limit undermining of our flaps and preserve abdominal perforators for very good results. Based on the extent and amount of excess abdominal tissue, we will decide which procedure works best for the patient. It could be paniculectomy with or without umbilical transposition, a traditional abdominoplasty, a fluid-delay abdominoplasty, a circumferential belt lipectomy or lower body lift, and Monsplasty. Upper arms. Might be very surprised, many patients have excess arm tissue as of a great concern because they are more visible. The appearance of arm might be the only concern or might be one of the many concerns. The contraindications to do this surgery would be lymphedema, arterial or venous insufficiencies, patients who have undergone axillary lymph node dissection or radiation. Examination of the patient should assess just not the excess arm tissue that is mainly located in the medial side, but also assess the excess tissue of the forearm, lateral thoracic region, and the axilla. Point out any asymmetries or constrictive bands. The aim of the surgery is to restore the contour of the arm and the adjacent structures, and also to place the scar so that it's not easily seen. Brachioplasty can be standard or extended. You could use liposuction as well because it creates a safe plane for dissection and removes excess fat. Scar is obvious, so it's critical to place near bicipital groove or little posterior medial location. It's critical not to put too much of tension on the scar by over-resection. Important to include the deep dermal suture to the axillary fascia to avoid scar widening. Complications associated with brachioplasty have been skin dehiscence, seroma, infection, hematoma, skin necrosis, and DVT. There are more other complications as well. It's important the patient does not abduct the arm for a few days after the surgery. Compression garment compliance is of critical. Breasts. In the patients, the breasts are deflated with a significant volume loss, and they could be asymmetric, and they have axillary roll which extend to the lateral chest wall. The various ways of managing the breast could be one of the following: mastopexy, or mastopexy with auto-augmentation. With augmentation here, we mean the lateral roll being accentuating the lateral aspect of the breast. Or that's called auto-augmentation, or we might need to use an implant. In some cases, there's still a significant amount of breast tissue left, so that would be a breast reduction. For the deflated breast, we would use extended Weiss pattern, where the lateral roll is rolled into the lateral aspect of the breast. Large area of de-epithelialization is expected. Superior, medial, and lateral flaps are elevated. Central mount of the breast is secured to the chest wall. Shape is adjusted with plication of the sutures. The breast skin is then draped over the breast. Excess tissue in the back. Upper back rolls can be resected by direct excision, or it can be as part of the extension of lateral breast. Lower back roll can be addressed by extension of belt lipectomy. We need to make sure we want to align the scar, so this is obscured under the clothing. Circumferential excess. Inadequate treatment by addressing only anteriorly can lead to worsening of the posterior and lateral contours. Circumferential belt lipectomy, which composes of abdominoplasty, lateral thigh lift, buttock lift, and liposuction. Further refinements have been made by auto-augmentation of the buttocks. Complications associated with this procedure are seroma, wound dehiscence, flap necrosis, DVT, and PE. Thighs. Excess tissue around thighs. Lateral thigh laxity can be addressed with lower body lift by a superior pull. Transverse scar to address the vertical medial thigh excess. When you use transverse scar, keep the scar close to the mons. Ensure to anchor superficial fascial system to the Colles fascia to prevent the descent of the scar. This can be combined with the lower body lift. When you want to use a vertical scar, it can address the horizontal thigh excess. It extends from the groin almost up to the knee. Again, the extent of this is determined where the excess tissue is. You will need a transverse component for good result. Again, anchor the SFS to the Colles fascia. Buttocks. This can be part of the lower body lift, when you also can do gluteal auto-augmentation, and lately also we've started considering adding a fat. Complications are hematoma, seroma, lymphocele, DVT, PE, wound dehiscence, and recurrent skin laxity. Post-op care. We have to educate our patients about drain and let them know how long the drains are going to remain, and teach them how to maintain the drains and record the output. Patients also need to be compliant with the compression dressing. They need to be well hydrated, especially in the immediate post-op period. They have to be motivated to ambulate as much as possible within their comfort limits. And we need to use Lovenox when required. They have to be told to avoid strenuous exercise at least for 4 weeks. And if the most common complication is seroma, and we have to tell them about how we're going to go about treating that if it occurs. In conclusion, I would like to say that body contouring procedures have a powerful impact on the patient's well-being. We need to be meticulous in the patient selection, establish realistic expectations with the patient, and provide a safe and a reliable technique. I would like to thank all the listeners, and I would like you all to explore these options of body contouring at KCH. Thank you very much.